Good afternoon, ladies and gentlemen. It is great honor to have a chance to present my clinical experience in this wonderful symposium. And my name is Kyung-Yeol Ho, and I'm working at Suncheonhyang University Hospital in Seoul, Korea. Today, I'm going to talk about the total duodenal exclusion with pyloric sphincter preservation for low BMI type diabetes. Another name of this procedure is a single anastomosis PyloroEnterostomy. I think the surgeon's role in treatment of metabolic disease is undoubtedly amelioration of a metabolic problem. But more important thing is the surgeon should have to guarantee surgical safety and the post-operative better GI quality of life, because surgical complications are usually vexatious impact on life quality, even lifelong, permanently. Anyway, I have been doing the metabolic surgery, the single anastomosis gastric bypass is the same as a modified mini gastric bypass since 2009. It was conducted 183 patients of type 2 diabetes with BMI less than 30. The mean BMI was 25, and this procedure was acceptable outcome. The hypoglycemia was controlled more than 80% of patients, and there was no recurrent hypoglycemia, and no mortality and major complications. So it was a safe operation and effective anti-diabetic surgery. We thought that the underlying mechanisms behind the excellent outcomes are due to the complete exclusion of FOGAT from nutrient. Then it follows the down-regulation of the GIP, the bad incretin in the diabetes, to half within 1 month, about 53% compared to the pre-operative state. And the other one is expedite delivery of the nutrient to this decimal bowel. This makes the upregulation of GLP-1 to the 3 times compared to the pre-operative period. Is very much excellent effect comparable to the biliopancreatic diversion. Here is the multiple, there was a multiple physiologic event followed the incretin change. As you can see this graph, the HbA1c and the disposition index show continuous steady improvement of diabetes. But first couple of years, the main mechanism was the increased insulin sensitivity. After that, the pancreatic functional improvement was take over the role of improvement, just like the yellow bar is shown in the graph. So different event was conducted as sequentially and independently to improve the diabetic metabolic abnormalities. But our surgery has some drawback. Vexatious gastrointestinal symptoms from the absence of the pyloric sphincter makes marginal ulcer and biliplus and dumping syndrome, something like that. And the more serious thing is difficulties in endoscopic surveillance of bypassed stomach due to the possible incidence of the gastric cancer in the bypassed area. I think the possibility of the gastric cancer in the bypassed area is negligible, but our country is endemic for the gastric cancer, so our patient had a bad memory of the incident had suffering the gastric cancer long duration and very severely. So I can't perform furthermore this operation, so I have to do something. The modification of surgery was mandatory. The modification was conducted under the three principles strictly. The first one is preservation of pyloric sphincter, and this is for the better quality of life after surgery. And more than 200 cm of biliopancreatic rim was secured to prevent the anti-diabetic effect, potentiate the better anti-diabetic effect, and the total duodenal exclusion. This is to avoid recurrent hypoglycemia. I think the third principle, the total duodenal exclusion, has some debate and some question because the small area of duodenum. Why small area? What's the problem with the small area of duodenum? You may have a question for this the principle. So I'm going to discuss about this question about at the end of my presentation. Yes, through the infraduodenal tunneling, the duodenal first portion, just the distal to the pyloric sphincter, was transected with the linear stapler, and the 200 cm from the tricep ligament of small bowel is lifted up and anchored to the distal end of upper bowel, the distal stomach, and this anchored area is exteriorized through the epigastric small wound, and duodenal tissue is removed with electric cautery and harmonic scalpel. All the duodenal tissue is removed, and the small incision also made in the small bowel, and the interrotid suture is made between the sphincter muscle and the small intestine. The interrotid suture is very important in this procedure because not to deteriorate the sphincter, pyloric sphincter function. Okay, and from here I would like to show you the brief summary of our surgery. From December 2015, 79 patients underwent a safe procedure, and the two-year follow-up was possible for 14 patients. Hemoglobin A1C was decreased from 8.8 to 6.6, and there was no recurrent hypoglycemia, and there was no mortality and major surgical complication, and post-operative BMI change was negligible. I mean, this kind of surgery is weight-independent diabetic treatment surgery. And the post-operative gastrointestinal quality of life was much better than the prototype of surgery. This is very important. Before surgery, we aiming the two purposes. One is the same effect with the prototype of surgery, and the second one is improvement of life quality. We have made it with perfectly. And the discussion time about the small duodenal tissue left in the food passage tract. What matters with the small piece of duodenum? I think we have missed something very important that should have to take into consideration. That is normal physiologic responses which determine outcome of surgery. We have two items. One is a unique pattern of intestinal epithelial regeneration, and second is compensatory hypertrophy of residual small intestine. It's very important physiologic event. Now, first I would like to show you the intestinal regeneration pattern. It's very unique pattern, and the stem cell is all the stem cell is located in the bottom of the crypt, and then they migration upward and go into the top of the villi, and they shutting out. The important thing is just like this: the migration upward, and until the top of the villi, and they shutting out like this. The most important thing is the cellular determination. the destiny of cell type is determined by the mesenchyme of the villi. So the mesenchyme is control the cellular type, the differentiation. But when the two different bowel is anastomosed with the suture, just like this, the mesenchyme is mixed and the tangled or something. So the control of the cell differentiation is changed. And the second one is the shortcut end of jejunum is active and vivid area of compensatory hypertrophy and proliferation. This is what looks like after if we had the resection of small bowel because trauma or something, any cause, any purpose. If we resect the small bowel, massive small bowel resection, the residual small intestine is to cover the insufficient absorption of the nutrient and something like that. So they proliferate and hypertrophied to overcome the deficient nutrient absorption. So same physiological event is after the gastric bypass surgery. The connected jejunum is hypertrophied and the proliferation of villi and the number of villi is increased. The lumen is bigger than before. It's something like that kind of the compensatory reaction. If the two, just like this hypertrophy, and if the combination of both reaction may have a possibility of spreading of duodenal characteristic cell to the connected jejunum until the final stage of compensation. During the compensation, the cellular differentiation is very active. Just like this, the tangling of the duodenal tissue and jejunum and the hypertrophy of jejunum makes this kind of change of the connected jejunum to the duodenal epithelium. Why don't you confirm with the following document at the paper? First, you have to collect the DJB paper related to the low body weight diabetes control, and discriminate outcome acceptable or not, and check the location of sphincter. This surgery was pylorus prism or not, and check the clinical course, recurrence is present or not within a year, and compared to with the conclusion, you can find amazing things. I would like to show you a representative article of each group. The favorable group is the representative paper is original luminous paper. Effect of duodenal exclusion in non-obese animal model of type 2 diabetes, and the other one, the unfavorable group, is moderate effect of duodenal bypass. This is written by Dr. Cohen, the Brazilian doctor. Who is very interested in the low body weight type 2 diabetes treatment of the surgical. And both paper, you can read the document of in favorable group gastrojejunostomy. That means sphincter was exteriorized, that bypassed. And the unfavorable group, the duodenal, you can see the duodenal jejunostomy. Duodenal jejunostomy means that they preserve the pylorus sphincter. Check it. And this is very interesting things. We can compare the three different procedure. One is a surgical duodenal exclusion procedure, and this is medical duodenal jejunal bypass. Put in the liner, the barrier in the duodenal jejunal area, and the other one is the surgical duodenal preserving, pylorus sphincter preserving procedure. Among the three procedures, only this surgical preserving procedure has recurrence. You can see that the same area of the duodenal tissue is exposed in the endobarrier and the preserving surgery, but recurrence is limited in this surgical procedure because wide endobarrier does not recur, because the distance between the proximal and the distal bowel is too far, because the barrier is blocking the cellular transmission. So distance is too far. The duodenal cell does not go to the distal jejunal end of jejunum. So this is the reason why this is supporting evidence. Another one is the animal laboratory finding, and the surgery was the duodenal jejunal bypass, because the pylorus is preserved, so duodenum is left intact, and after 14 days after surgery, they reopened the abdomen of what happened? The distal bowel, connected bowel. They saw the hypertrophied bowel, but they described it like this. The general morphologic feature of the distal jejunum was rather similar to that of the duodenum in sham-operated rat. Looks like duodenum. And this is very interesting one, and this is classical biliopancreatic diversion, and this is a duodenal switch. Difference of the two procedures is the preservation of pylori and the stomach, because they tried the biliopancreatic diversion without minimize the surgical complication. That means the intention of this modification is same as our surgery, to improve the post-operative life quality. But in my three principles, the classical BPD satisfies only two principles, and the other one, the pyrosphincter preservation was not possible, and in this right side, the duodenal switch, the total duodenal exclusion was impossible. So the first one, the classic, the BPD the problem is the poor life quality, and this side one is the not recurrence of the glycemia. So they mentioned like this: in assessing the long-term metabolic effect of duodenal switch without gastric resection, in this side picture, we have some reservation about the efficacy of the method in controlling type 2 diabetes. That means I think the recurrent was observed in this case. This is very interesting one. This paper is written to compare the Roux-en-Y gastric bypass and the duodenal jejunal bypass. Its effectiveness of the low body weight type 2DM. They observed the patient 3 years after surgery, and they concluded that duodenal jejunal bypass is not an effective method of controlling type 2 DM, and even they say Fogat theory may not be the main mechanism of diabetes control during bariatric surgery. But the important thing is the technique of DJB is I don't like their method, because they preserve the pylorus and they left to the relatively long segment, 3 to 4 cm, and the source of the recurrence, and they only left the piperin, the 70 cm. Let's see the outcome. Look at this dark field. The square is the duodenal jejunal bypass 1, 2, 3, 4. The all parameter of the obesity and diabetic parameter was recovered pattern in 3 months after surgery. Because I think that is the reason why they left the duodenal tissue. This is very solid evidence of my hypothesis. Okay, this is the final slide, take-home message. Anti-diabetic efficacy is essential in metabolic surgery field, but safety and post-operative life quality is more important. Secondly, anastomosis between pyloric sphincter muscle with the intestine is safe and effective, exclusively interrupted manner, and take into consideration of post-operative compensatory proliferation, hypertrophy, and the unique pattern of intestinal epithelial regeneration concomitantly at the same time. That may have the solution. The enigma can be solved with this idea. Thank you so much for listening.